efforts towards cancer control and prevention in sub-Saharan Africa and also in Kenya. The best person to take us through this session is Anne Korir. Anne Korir is an accomplished senior research scientist with expertise in cancer epidemiology, working at the Kenya Medical Research Institute at the Nairobi Population-Based Cancer Registry, and has been instrumental in establishment of cancer registries in Kenya and in Sub-Saharan Africa region, more specifically capacity building registries in the region in terms of how to establish population-based cancer registries and also technical support. And her leadership, she has really propelled the Nairobi Cancer Registry to be a leader in cancer registration in the region, notably the recent designation of the Nairobi Cancer Registry as the Center of Expertise for Sub-Saharan Africa, majorly focusing on capacity building and issues of making sure that registries are able to really utilize the data that they generate. And she's a peer of several research studies focusing on cancer epidemiology and disparities among Black populations, and has served in several technical committees in the Ministry of Health and also internationally. She will be able to take us through this session. She's also global trainer, GICRnet, and she will tell us more about what GICRnet stands for. Welcome, Anne, to take us through the presentation. So, all right. Yeah, I think I can. If Anne, are you in a position to hear us? If you can unmute.
Yes, I can hear you. Thank you so much, Evans, for that introduction.
Are you able to share the slides, or I can be able to share for you the PowerPoint?
Yeah, please share the slides.
All right,
on your
okay.
side.
If you just confirming if you can be able to see the slides.
Yes, Evans, I can see the slides. You need to just put on the presentation mode.
All right.
Okay, great. So good morning, good afternoon, everybody. It's a pleasure to be here today to be part of this panel discussion. Thank you so much for creating time for us to be able to present about the work that we do at KEMRI. The reason for this presentation is to really create awareness about cancer registration, to create awareness about cancer registries, why they're important, and also to invite collaboration, cooperation, partnership from all the stakeholders that are involved in this activity. So it's really a pleasure to be here. As Evans has mentioned, my name is Anne Korir, and I'm the head of the Nairobi Cancer Registry. I'm a research scientist at KEMRI at the Center for Clinical Research. And I'm also the principal investigator for the newly established center, the GICR Center of Expertise for Sub-Saharan Africa, that is based at KEMRI. Next slide. So when we talk about cancer registration, what do we mean? A lot of times when we do our work, sometimes maybe we stay for a month before we go back to the facility, and the staff at the facility are wondering, why are you coming again? We thought you finished this work. So cancer registration really is a continuing systematic collection of data on the occurrence, characteristics, and outcomes of reportable neoplasms. So it is continuous. You cannot say that you have done cancer registration and now you have stopped. It's a continuing activity. Once you begin, it will run for years. As long as cancer is still with us, cancer registration will continue. So it's a continuing systematic collection of data on the occurrence, characteristics, and outcomes of reportable neoplasms or of cancer. And the purpose is to assess and control the impact of malignant disease in the community. Next slide. So a cancer registry is an office or institution responsible for the collection, storage, analysis, and interpretation of data on persons with cancer. So basically, like the Nairobi Cancer Registry, this is an office within an institution, and this institution is KEMRI. So it is an office that is responsible for the collection, for collating, for storing, analyzing, and interpreting that data and disseminating it so that it can be utilized for the purposes that it is intended for. So basically, a cancer registry is just an office for doing this work. Okay. Next slide. So there are several types of registries. So there are registries that we call population-based cancer registries. We have hospital-based cancer registries, and we have what we call special cancer registries or special registries, right? So what is a population-based registry? So basically, a population-based registry focuses on the population, and it collects data on all cases occurring in a defined population. So an example again, Nairobi Cancer Registry, what coverage does it, where does it cover? It covers Nairobi as the population. So you need to have a defined population for you to talk about population-based registry. And the sources of data for this particular population are multiple. So basically you're getting data from all the hospitals and all other diagnostic centers, as long as they are diagnosing cancer cases. And then for the hospital-based registry, again, the focus is hospital. So this is a hospital where they put a system of all the cases that are seen in that particular hospital. So the records information on cancer cases treated within that specific hospital. And for the specific hospital, then it means that the patients who are seen there are patients who have come to seek treatment there. How is it different from population-based? For population-based, the cases will have been treated from multiple hospitals, several different hospitals, but the focus is the population. So you will go to hospital A, hospital B, C, D, but you will only be focusing on the cases for the defined population. So like in our case, only the cases that are residents of Nairobi will be our focus, but the sources will be multiple. All the hospitals within Nairobi, diagnostic centers, and many other different sources. And what are the special registries? These are registries that collect specific cancers. For example, you can have a childhood cancer registry just to collect childhood cancers. You can have a specific type of cancer, like maybe brain tumor registry. So you'll only be recording brain tumor. So it is defined, it's specified, very specific, this one. Okay, next slide. So when we look at these types of registries, each of them has a specific purpose. There's a reason why we maintain a hospital-based registry. There's a reason why we maintain pathology-based registry, which is also one of the special registries. And there's a reason why we maintain a population-based registry. So what are the characteristics of these different types of registries? So as I mentioned, for hospital-based, it collects information on all cases treated in a specified hospital. And therefore, it is useful for administrative purposes, for reviewing clinical performance, for planning. So hospital planning, the hospital will be able to understand the magnitude of the work that is required. So they'll be able to plan for resources. They might want to plan for purchasing, certain equipment that will go into treatment or go into diagnostics. They might want to hire more specialized, staff to be able to manage the cases that they are seeing. So basically for hospital-based registry, the usefulness is in the planning for clinical services within that specified hospital. They'll be able to also use it to review how are they doing. They'll be able to review the performance. How are the patients responding to this particular regimen, for example? So they'll be able to utilize that registry for so many different purposes. Now, can we be able to use the hospital in the formulation of national plans? This is from UICC, and they say that no, you cannot be able to use a hospital-based data for planning, for making cancer plans, or for informing cancer control programs, because it will be incomplete and it is not representative of a population. When it comes to the other registry, which is a special registry called pathology-based registry, this one specifically collects data that have been, cases diagnosed histologically or morphologically. So cases that are diagnosed either through biopsy or, through when you do a biopsy or you do FNA, so you'll have only done morphological diagnosis. So this specific registry only maintains this data. So it will ignore all the other cases diagnosed radiologically or even just clinically. What's the purpose of this registry? It supports the need for laboratory-based services. So you'll be able then to see whether you need, again, to improve on the diagnostics. Maybe you need more pathologists. Maybe you need to be able to establish more histopathology labs. You'll be able to use this data for that. Can it be used in making cancer control plans? Again, the suggestion by UICC is that no, because it's incomplete, it is not accurate, it's not a specific sample that is representative of a population. And then, so the other one is the population-based cancer registry. As I mentioned, this one systematically collects information from multiple sources. So it will not get data from one hospital. It gets data from so many different hospitals. But then the focus is a population. So yes, sometimes you have like a country, for example, a country like Kenya, where you have a very big population. What do? You need to be able to sample and just pick a small population and focus on that. In research, there's something called sampling. Even when you're doing your research and you're supposed to interview people in Nairobi, you're not going to interview every single person in Nairobi. You will sample a representative population. So it's the same concept for population-based registry. You focus on a small population, but you are complete in the sense that you are including every single case of cancer in that particular population. So it is needed to compute, the purpose of this registry is needed to compute cancer statistics. For instance, the cancer burden. When we talk about the cancer burden, we're talking about incidence, we're talking about mortality, you're talking about the prevalence. What's the prevalence of cancer in the last 5 years? What's the incidence of cancer this year? How different is it from the incidence of cancer last year? So you're looking at the burden, mortality. How many people are dying of cancer? Which are the leading cancers in our population? Which cancer is killing our women? Which cancer is killing our children? What can we do about it? Can we then control this particular burden? So population-based registries, the purpose is really to understand the burden of disease in that specific population, so that then we can be able to utilize that information to be able to plan for interventions. So again, this is from UICC. Is this data from this population, can it be used to formulate national cancer plans? And the answer is yes. A systematic ascertainment of all cases from multiple sources. Remember, it's not one source, it's not one hospital. It's all the hospitals that are diagnosing cancer within the population. So because you've gotten all that data from different hospitals, right? So it becomes then a representative of the country. So you can be able to use this data for planning cancer control programs, for thinking about interventions. How can we intervene to reduce the burden of cancer? How can we be able to intervene to reduce these cases that are killing our children? How can we be able to intervene to prevent cancer so that it doesn't even occur? So that is when we talk about preventive measures. Like, for example, we can say, cervical cancer is killing our women. So what do? We need to screen. We need to be able to also roll out vaccination of young girls. So those are interventions arising from the data, that you have looked at from a population-based registry. So it's important to understand those three differences. They are all important, but then what does the other one do? How is it different from the other type of registry? So a population-based registry is considered the gold standard of cancer registries, and its aim is to be established. The aim is for these registries to be established in all countries. I'll show you a chart later, or rather a map showing the registries that have been established globally. So characteristics of this registry: collects data on all new cases of cancer occurring in a defined population, and it provides epidemiological data for public health surveillance and program planning, right? So you can be able to use it for intervention. For the national cancer control programs, they can be able to use this data to tell us what are you going to do as a country in the next 5 years. So they will use the existing data to plan and be able then to put in place a plan or a plan of action or intervention that we're going to do to reduce the burden. So the strengths of this, it describes cancer burden in the population. It sets priorities and plans for evaluation of cancer control programs. Next slide. So we've already talked about multiple sources. So when we talk about multiple sources, what do we mean exactly? So the sources of population-based registries come from mainly the places that diagnose or manage cancer. So when we look at this chart here on my screen, you see the clinics, you see laboratories, you see hospitals. So you also see vital statistics. For instance, the registries of births and deaths. They have vital statistics. If you go to the registries of births and deaths, they'll be able to tell us that these are the mortality data. And from this mortality data, they'll be able to tell us, oh, for cancer, these are the number of people dying of cancer. So the registry needs that information as well to include in their database, so that then they can be able to tell the nation, or be able to tell the key stakeholders on the burden, the total burden, not just the incidence, but also the mortality. So basically, you're looking at hospital sources. So all the hospitals, as long as these hospitals are diagnosing or managing or treating cancer, they are a source for the population-based registry. Diagnostic labs and imaging centers, these are very important, because you'll be able then to scrutinize to see, of all these diagnoses that they have done, which ones were specific for cancer, which one show us that cancer is, the cancer was diagnosed, or the tumor that was taken to the lab, when they tested, when they checked, it was malignant. So that the malignant cases is what now ends up in the registry. And then I talked about the death certificate from the vital statistics. That is also important, so that then we can be able to analyze that data and also show the survival. I have attended meetings where people say, oh, we only talk about cancer like it's killing people. How about survival? How many people are surviving from breast cancer? How many people are surviving from cervical cancer? How many from prostate cancer? So people also need to know survival. But you cannot calculate this unless you have information from the vital statistics, so that then you can link your databases and be able to tell the rate, or rather the mortality rate from cancer. Next slide. Okay, so the methods for data collection in a registry, we have several methods. You can use what you call active case finding. And this is what we've used mainly in the Nairobi registry. Active case finding involves collecting data at the source by the registry staff. So in this case, we have staff from KEMRI that are trained. These are people that have gone through rigorous training. These are people that have signed confidentiality forms. These are people that have been trained on ethics and confidentiality and have been able to sign several documents towards that, to be able to protect patient data. So these are people that we train and then we send to different hospitals. So I'm sure some of you have already interacted with these people. They come to you on a daily basis or regular basis. Some hospitals, we are not there daily because of the workload. Sometimes you're only there maybe after every 2 weeks, others after 1 month. But there are those big hospitals where we have our people stationed almost throughout on a daily basis because of the workload. So this is what we call active case finding. They are going to those facilities to actively look for these cases that meet the inclusion criteria to be included in the population-based registry. Then we have what we call passive case finding. So for passive case finding, we do not send the staff. So the staff in those facilities are the ones that send the data to us, to the registry office, right? So they submit the data. They have already also been trained, and they know that these are the people that meet these are the cases that meet the criteria. So they collect those cases and then submit that data to the registry or notify the registry. And this is one of the methods that is used for the National Cancer Registry at the National Cancer Institute. They mainly use passive case finding, where you're expected, as staff in the hospital, you're expected to notify the National Cancer Institute. So that is called passive case finding. There's also what we call automated, where you're using information already stored in the system. So you are just linking the the systems, the hospital-based system to the registry system. So you pull out the data from the hospital-based system. So these are in places where computerization has taken effect, where you don't even have paper records anymore. You only have computer systems. I have seen these in places where I've visited in other registries across the world. You go to these registries and you find nobody even moves from their desk. They just sit in their offices and they log into this system, they log into the other system, and they are able to pull out the data and be able then to pull into the registry automatically. So that is also a very good system of collecting data. Our goal as Kenya is to get there someday. Right. So we have so many different manuals. As I mentioned, this work is actually led internationally by WHO. We have International Agency for Research on Cancer, IAC. IAC is a research arm of WHO, and they are the global leaders as far as cancer registration is concerned. And they have published so many, publications or technical reports that go into supporting the work of cancer registration globally. We also have the Africa Cancer Registries Network. The Africa Cancer Registries Network is a group of cancer registries, population-based cancer registries that came together to say, how can we work together to strengthen cancer registration in Africa? So we formed this way back in 2012, where Nairobi Cancer Registry was one of the founding members of this Africa Cancer Registries Network. And together with registries across sub-Saharan Africa, we've been able to build a very strong network where we work together, we support each other, where we have challenges, we're able to share the challenges. Where we have successes, we also share those successes. So one of the successes was publishing this standard procedure manual. So this is a manual that is used for population-based registries to guide on the work that we do. So these documents are very important. And whenever we invite people for training, these are some of the things that we take them through. We also have the ICDO. Those of us in the health records and information, you will know about the ICD-10, or currently we have ICD-11. So for cancer specifically, we have ICDO, so International Classification of Diseases for Oncology. And this is just a coding manual that we use to code malignancies. And then we have also what we call TNM. So the TNM classification, we are able to code the stages, cancer staging using TNM. And there are many other resources that we use for the cancer registry staff. Next slide. Okay, so the variables, what are the variables that we collect for the cancer registry? So we usually classify them into these categories here: the person, the tumor, the sources of information, and follow-up. So under the person, what do we want to collect from the person? We need the identifiable information. We need to be able to get the dates of birth. We need to be able to collect the gender or the sex. And then ethnicity. It's not very, very important, but some registries really are able to collect this data, and AFCRN recommends that we collect this variable. We know that it's very controversial in some countries, but we collect it for the positive things in ethnicity because we just want to see whether there's any linkage, to the occurrence of cancer. And then, of course, the address or the place of residence, we also are able to collect. Where do the person live or where do the person stay? That is the place of residence. And then for the tumor, what do we collect? We need the incidence date. We need to be able to collect the site of primary. When I talk about the primary site, specifically, I'm saying where was the cancer? What is the origin of the cancer? Because sometimes the cancer can spread to different sites, but our interest is the primary site, the occurrence, where it first started. And then we have the histology. What is the morphology or the specific morphological cells that are affected by cancer? And then we have behavior. So behavior, basically we're saying, is the cancer malignant? Is it benign? Is it borderline? And the registry usually focuses more on the malignant tumors. Sometimes we collect, like for brain tumors, we can collect borderline tumors, but mainly we collect the malignant tumors. Laterality, so this is for where we have two organs. So which part, was it the left part or was it the right part of the organ? And then basis of diagnosis, what was the basis of diagnosis? Was it through histology? Was it through imaging? So we are able to classify the basis of diagnosis. We also collect stage. So staging is important. If we have clinicians in the room, we really need staging documented. I have met doctors where, they are able to, prescribe the treatment. And sometimes I go further to ask, what was the stage? What was the basis of prescribing this regimen? And they say, oh, we know the stage. It's just that it's not documented on the file. Please document, because the cancer registries are third parties. Cancer registry staff, they come to peruse through these records to collect this information. So we need you to kindly document the staging in the patient file, or document some information that can help us to even allocate the stage information, because it is required by the National Cancer Control Planners. They need to understand at what stage are we diagnosing the tumors, the cancers that we see in the population. We also collect information on treatment, initial therapy. What was the initial treatment that was given? Was it radiotherapy only, or was it radio combined with chemotherapy, or was it chemo only? Was it hormonal? We need to be able to understand, because the planners, again, they want to be able to understand what is the treatment that we are prescribing to our patient. The sources of information, we document the sources. As I mentioned earlier, the sources will be either hospitals or diagnostic centers, labs, imaging centers, even hospices where the patient has gone for care. All those sources are very important for us. The vital statistics also, like the data from the registries of births and deaths. We collect data from there so that we can be able to understand the mortality or the survival of cancer. Follow-up information, we need to document the last contact dates and be able also to then document the date of death in the event the patient dies of this disease, and of course the cause of death. So these are the variables. They are not many, they are very few, but they are very, very important for the cancer registries, okay? So I've already mentioned under the person that we will collect identifiers like age, like sex, like the ID number, like the telephone number. These are very, very important for us to be able to collect and include in the database, because we want to link. Remember, a patient will go to, for example, today we are talking about to Kenyatta National Hospital. So a patient will go to Kenyatta National Hospital today, be diagnosed at Kenyatta National Hospital, maybe even begin treatment, and then eventually moves to another hospital, maybe for something else, the same patient. So we need to be able to then in the registry say, this person is the same one that was treated at Kenyatta National Hospital, has moved from Kenyatta National Hospital to another hospital. It is the same patient. And we have seen that in the registry, patients can actually go to 3 or 4 different sources, and we need to be able to link. If we cannot link, if we don't collect this identifiable information, then we will not be able to link. And if we cannot link, what do? We give you wrong data, right? We give you data that is overestimated. that is showing that cancer is maybe 3 or 4 times more, because you will have counted these cases as single cases from each of these hospitals that they have visited. So we need these identifiers so that we can be able to link and be able to show that this is the same patient that moved from one hospital to the other, seeking different kind of regimen or care. So population-based registry should ensure data security in storage and handling. So yes, in Nairobi Registry, we have adhered to all the standards that are required so that we are able to then protect. It is very, very important to protect. And as you all know, Cambridge being a research institution, they are very strong on ethics. And so we are able then to be able to put in place measures that can protect the privacy and the security of the data of the patients that we see in our facilities, so that we only use that data for the purposes that are intended for. We are able to use that data to inform cancer control, to reduce the burden of cancer in the community. That is the only purpose why we maintain this data. So we've been able then to, adhere to all the standards as far as storage and handling of data is concerned. We've also complied with the recent Data Protection Act. As you all know, there's a new Data Protection Act, and we've been able to comply. Cambridge has been has already been given the certificate as a data controller and data processor by the ODPC, the Office of the Data Protection Commission. We've been able to get certified because this was a requirement by the hospitals, that, oh, now we have this data protection. What do you do? And so we went back to talk to the ODPC, and they said, oh, it's not a problem. You just need to be certified. And so we followed all the procedures to get Cambridge certified, and all our staff as well trained, and so that they can be able to adhere to these new regulations. Next slide. Okay, so the uses of population-based cancer registry. As I mentioned, it is very important for to inform cancer control program in the country. So it informs cancer burden and time trends. So the registry, like our registry, was started way back, over 20 years ago. So when we look at the data from the registry, we can be able even to tell the trends over time, If you look at, for example, data that we used to collect over 20 years ago, the top cancers, yes, there have been slight changes, but then you can be able to also attribute those changes to the interventions. For example, Kaposi sarcoma was one of the leading cancers in men. It was actually the highest, KS. And why was that? Because of the HIV burden. But when we put in place measures to control the HIV, what happened? The Kaposi sarcoma dropped, right? So you can be able to look at time trends. You can be able to look at trends over time and attribute it to the interventions that we have put in place as a country, the control measures, right? So the people who are in the office then, they were able to see, oh, KS is so high. So they put in place measures. And when we were able then to control the HIV, then the Kaposi sarcoma also was controlled. So that is the purpose of a population-based registry. Provides trends over time, the burden of the disease in the population. We can also be able to use it to guide patient care, right? So the doctors can be able to use this data to specifically guide on the patient care. They might have used this regimen on these patients, and then they'll be like, okay, we see that maybe the survival was not, good for when we use this regimen compared to when we use this other regimen. So then they'll be able to use that data to then be able to monitor patient care and be able then to give the best care to the patient. They'll also use this data to guide on cancer research. So yes, this data then becomes data that can be used for research. Researchers want to know which are the priority cancers that we need to focus on as a country, right? So they will use that data to guide the research. They will use it also to formulate hypotheses about cancer. Yes, so when you look at the data, then you can also formulate a hypothesis, about etiology. What are the causes of cancer? What is causing cancer? Then you can formulate your hypothesis and be able to go into the research aspect and be able to then to answer your your research questions. You can use this data to assess potential cancer clusters. So when you group that data, then you can be able to tell, where do we have clusters? And what could be then the reason for that? Then you can investigate. You can use that to also evaluate impact of interventions. So we have been able then to also put in place things like cancer screening using the data from the registry. When we were able to see that cervical cancer is one of the leading cancers, breast cancer, then what do the National Cancer Control Program do? They then guide and say, we need to have nationwide screening to reduce this burden, okay? So these are some of the uses of population-based registries, right? So maybe next slide. Okay, so when we then talk about uses of the population-based registry, we are also looking at, you now have the evidence, after you quantify the cancer burden using data from the population, then you have evidence then to be able to show that cancer is a burden, and then you're able then to plan, right? So you plan, so you have evidence-based cancer control intervention, so you plan for intervention, and then you can also evaluate. By evaluating, you're just monitoring the progress of what you have invested in, right? So you monitor the progress to see how are we doing as far as cancer control is concerned, right? So the data is very useful for this, for evaluating cancer control programs. And then eventually then you can also be able to use that data for research, right? You can be able to come up with descriptive research just by analyzing the data, analytic and clinical epidemiological studies, by formulating hypotheses, and be able to then generate research questions to be able then to investigate and be able to come up with evidence, right? So it is like a cycle. It goes, it's like a wheel, right? You plan, you evaluate, you do research, then you have evidence, and that evidence can help you also to plan further. And it is a continuous process, right? So that's why I said cancer registration is a continuous process, especially for population-based registry. As long as cancer is here with us, then you need to keep evaluating, planning, researching, and generating evidence to control the disease. Next slide. My apologies on the background noise. Where I'm seated is a bit noisy. Right, so there are so many, as I mentioned earlier, I talked about IAC, and they have been able then to, generate publications from the data that is, generated from registries globally across the world. So we have, I believe you've seen something called Global or Globocan. Globocan is a publication from IAC, and they release this publication based on the data that we submit from the registries. As I mentioned, the data is used locally to inform cancer control program, and it goes all the way up to WHO, where then they are able to inform us also global, for global cancer control as well. So if you look at, maybe when you have time, you can Google this Global Cancer Observatory, or just Google Globocan, and then you can be able then to look at the different data from across the world. You can look at data currently, where it will show you incidence data for each country or for each population globally. If you want to look at Kenya, you can click Kenya. Maybe you want to look at Africa. Maybe you're interested in East Africa, or you're interested in, Western Australia. Any country you can think of, you go in here and you're able to, it is a platform, so it is interactive. So you can click and, just select whatever you need. So this is data that is coming from registries. They don't just publish this, put up this publication from, from the blue. They use data from cancer registries. They've also published, down here, you will see so many different volumes of cancer in 5 continents. So we have something called cancer incidence in 5 continents, and it's also published by IAC. And this is data that is of high quality. They only publish high quality data. We may have registries, many registries, but not all of them are of high quality. So only high quality data is published here. And in Africa, the registries that have published here are very few. So we are still not there as Africa. We are privileged as Nairobi Registry. We've been able to publish in 2 of these. As you can see, this is volume 1 to volume 12. Nairobi has only been able to publish in volume 11 and volume 12. So it takes time to, to be able to generate, to be able to produce high quality data. You need to be able to, you need to be complete in your case finding and registration. You need to be thorough. Your staff need to be well trained so that they collect good information. So you can see in Africa, very few registries have published. We have, you can see all the registries here on my chart. Because of time, I may not go into it, but you can see Nairobi there. You can see Nairobi, we've published in 2 volumes, volume 11 and volume 12. In Kenya also, we have Eldoret Cancer Registry that is located at Moi University. It's a population-based registry, and they've published in volume 12. The next release will be volume 13, and we are hoping that these 2 registries will also be included in volume 13. It's a lot of work, but we are hoping, working together with our stakeholders, we will be able then to achieve that. And you can see the map here. You can see the map here. This map represents the quality of data from registries. So we have registries globally. Every country, they have registries. What you see in blue is high quality. So you can see the South America, the North America, Asia, Europe, very, very good registries there. But when you come down to Africa, you see very few blue. The rest are, the yellow. It means that there is a population-based registry, yes, but it's not high quality. You can see Kenya there is painted blue because of the 2 registries, Nairobi and Eldoret Registry, because the only data that is put in here is population-based data. So it's not to say that, the other registries are not, it's only because they focus on population-based data. So that's why we have only the 2 registries. But of course, we have more registries in Kenya, and we are hoping that we will get more registries publishing in this, or getting into the CI5, so that then we know that they are producing high quality data. So in Africa, we still need to work very hard to improve the data that we generate. Okay. So these are just some parameters to measure the quality. They use completeness. How complete are we? Are we getting data from the civil registration of births and deaths? Are we getting data from all the hospitals, right? Then the accuracy, then the timeliness. Are we timely in our reporting? Comparability, representativeness. So all these are the parameters that they use to measure the quality of data. Next slide. So we know that population-based registries in sub-Saharan Africa, they face so many challenges, structural challenges, technical, resource challenges. Funding is a major issue. Institutionalization is a major issue. So all these affect the quality of the data that we generate. But we are hoping that as we advocate, like one of the reasons we are doing today is to advocate. And so I know that today we have over 300 people here in the room. They will be our champions also to promote the importance of population-based registry. So we want to continue to advocate. In some developed countries, you find that cancer registries are like institutions. They're actually funded by the government fully. But as we still over-rely on donor funding, we keep seeking out donor funding, we are still crumbling with so many challenges because they don't consider this data as important. But it is very important, and we need to continue to advocate for our institutions to support registries and for funding from our governments. We need funding so that we don't over-rely on donor funding. So, despite all these challenges, we have key stakeholders like the Africa Cancer Registries Network, WHO, IAC, we have the Ministries of Health. Now we have our big brother, National Cancer Institute, and we are hoping that working together with all these stakeholders, we can improve the quality of data. We can improve our capacity and be able to sustain our registry so that we don't begin the registries and then they die because of resource challenges. All right. Okay, so quickly, let me talk about the Center of Expertise. So Nairobi Cancer Registry, as I mentioned, was designated one of the centers of expertise for Sub-Saharan Africa. We have 3 centers, actually. We have one in South Africa. So the South Africa Center is based at the National Cancer Registry of South Africa, and they are responsible for research and also training in development of childhood cancer registries and data linkage, linking data from the registry to other registries like the screening registry, like the HIV databases. So they're responsible for that. We have another center in Cote d'Ivoire, Ivory Coast. So this center is similar to Nairobi. We are responsible for training in cancer registration. So we train the region, the Sub-Saharan Africa region, to establish more registries, or when they have registries, to improve their data so that the data is high quality. So that is the role we were given as Nairobi, to be able to offer trainings across Sub-Saharan Africa and be able to support, in terms of technical challenges, in terms of mentorship. We are able to support registries across the region. And our big brother in Cote d'Ivoire, they are also doing the same, but for the French-speaking countries of the region. So these centers were launched in November 2022 by IAC, WHO, together with partners like the Vital Strategies, and many other partners that are working together towards strengthening these registries in Africa. We also have the U.S. National Cancer Institute, USNCI, that have also come in to support the registries to strengthen the capacity of these centers so that they can perform optimally and be able to support the region so we can have high quality registries in the region. Next slide. Okay, so quickly just to share the data from the registry, you can see this is data from 2018 to 2022. And you can see that for women, breast cancer is the leading. So breast cancer is leading in women in Nairobi, followed very closely by cervical cancer. Then we have colorectal cancer. We have head and neck cancer like the mouth and pharynx. We have esophageal cancer, lymphomas, ovarian, in that order. So those are some of the leading cancers currently that we have in the registry. But I believe this period, the data is still changing in this period. So this is still not the final report. When we complete this, because I know that data for 2022 is still being collected. So this is not the final release. So these figures could change slightly. Go back, kindly. Yes, so the figures could change slightly. And then for the men, you can see we have prostate cancer is the leading in men. We have mouth and pharynx or oral cancers. We have colorectal, we have esophageal, lymphomas, stomach, leukemia, lung cancer, liver, brain tumors. Again, this is not final, so these figures could still change when we have included data from all the facilities. So we are still not complete for this particular period. Data collection is still ongoing, so this might change slightly. Next slide. Okay, so this is just when you see the data by age group, you can be able then to see that, a lot of our cases are falling between the ages of 30 to 69. So it is a younger population. So most of our cancers are diagnosed around these ages. And you can see specifically for women, the pink ones are women. You can see that 30 to 49, these are very, very young people. 30 to 49, over 2,500 cases, and then 50 to 69. So it shows that cancer is still being diagnosed at a younger age group. These are ages where people are still very active in the society. They're still taking care of their families, and you can see that we could be losing these people to cancer. Next slide. Okay, so this one is again another chart just showing the cases, the top 10 cases in terms of rates. And you can see overall, prostate cancer is leading, followed by breast cancer, followed by cervical cancer, and then we have colorectal cancer. So when you combine the cancers, both male and female, you can see then prostate is leading, followed by breast cancer, followed by cervical, and then colorectal, then esophageal. So those are like the top 5 cancers, prostate, breast, cervix, colorectal, esophageal. Those are the leading cancers that we are seeing within Nairobi when you combine the sexes. And then, of course, oral cancers are also very, very high. Lymphomas, you can see also the rates are coming up there, and stomach cancer. And as I mentioned, this is still, the data is still coming in. And then you can see lung cancer. It's also one of the top 10 cancers. Previously, we were not seeing lung cancer, but of late, we're beginning to see lung cancer coming up. So we need to be able to advocate against smoking, cigarette smoking, because you're seeing lung cancer is really coming up to the top 10. All right, these are just rates again, just showing the incidence rate by age group. And as you can see, the cancers are very high in the middle age groups, 30 to 39 to 49. This is where we have very, very high rates. Okay, right. Next slide, please. So in summary, cancer registries are the backbone of control or national cancer control. And without data, we plan in the dark. So with registries, we'll be able to guide policy, we'll be able to guide allocation of resources, and be able to also save lives. So it is very important that we maintain registries. It is a requirement by WHO. If WHO, actually when they come, I think there was one evaluation that was done by IAEA, International Atomic Agency. Okay, that one. When they came and they evaluated the country, one of the requirements of a country is that there should be population-based registries. And if they're not there, then you're graded lower, right? So it is a requirement internationally, globally, that we must maintain at least one or a few population-based registries in a country. So we need to be able to support these existing registries that we have and be able to strengthen them so that then we can have good data that is able to do what they're required to do, guide policy, guide resource allocation, and so that we can eventually save lives. We cannot do this alone. We need partnerships. I always say, if there's one thing that you cannot do alone, it is cancer registration. Partnerships is critical. We need to partner with hospitals. We need to partner with clinicians. We need to partner with even insurance companies, because, like the SHA, the NHIF, they have databases, data on cancer. We need to be able to access that data. We need to partner with researchers. There could be researchers that are specifically focusing on certain patients. Maybe they have enrolled certain patients for clinical research. We need to be able to access those so that we see, did we miss out on some patients in our registry, and therefore include those patients. We need to partner with communities, like the community health practitioners. They are very critical in telling us how many patients have died in the community, so that then we can also improve on data on survival. So partnerships and collaboration is critical, and we need the support from, all government, non-governmental organizations. We need their support so that we can produce high quality data that can inform our national cancer control planning. So let us commit to building strong, resilient, sustainable registries that will drive cancer response. I want to really thank especially the clinicians. We have clinicians that have really supported us over the years, They have really strongly supported the work in the cancer registry. They understand, they understand the value of cancer registries, and they really come out strongly to support. People like Professor Abinya, people like Alice Musibi, people, there are many, all the oncologists, I can name all of them, Gladwell Kiarie, all of them, they have supported the registries over the years. They write to us when they need the current data. They will write to us, and do we have current data on this? We are making a presentation here. We need to be able to link it also with the kind of data that we are generating. We thank all of you for the support that we have received over the years. And I urge that we work together so that we can also showcase what we have in Kenya. Next slide. All right, so I think this should be my final slide. So these are just resources that we need to, very important for registries. If you are a cancer registrar, you need to be able to look at the e-learning platform, we have produced e-learning material so that we can train people even faster across Africa and globally. This e-learning material is not just for Africa, it is for low and middle income countries. So you can be able to go into this website and learn and be able to even get a certificate as a cancer registrar at the end of the day, right? And we have so many other resources that are very important for the registries. I want to acknowledge all of you, first of all, for listening to me. I want to acknowledge Kenyatta National Hospital specifically for organizing this particular webinar. I really, really thank you for the support over the years. We appreciate KNH. You have really been a leader in this space, supporting us throughout. And, every time we have a new facility coming in place, we tell them, we've been working with KNH for the last 20 years, when we go to a place and they're like, oh, you're coming back again. We thought you finished this work last year. We're like, no. In fact, KNH, we've been working with them for the last 1 year. So thank you, KNH, for understanding the value of registries and supporting this work over the years. I want to thank NCI. We've been working very closely with Gladys Chesumbai, who are maintaining the National Cancer Registry. So when you see National Cancer Registry, don't say, oh, National Cancer Registry has replaced KEMRI. No, KEMRI is maintaining Nairobi Population-Based Cancer Registry, and the National Cancer Institute, NCI, is maintaining hospital-based registry network, a network of all the hospital-based registries. And I have shown you the different purposes of these registries. They complement each other. They do not compete with each other. They complement each other, and they are all important in our population. I also want to thank our partners, Ministry of Health, the National Cancer Control Program. They have been very, very supportive. They are the ones actually who consume this data. They are always looking for the new data that has come in. When is the new GloboCan release? GloboCan is estimated using data from Nairobi. Whenever you see GloboCan Kenya, just know that this is data from KEMRI and Eldoret Registry. It's just that it is extrapolated for the whole country, but it is the data that we generate and we share with WHO. I want to thank Vital Strategies and IAC and Africa Registries Network for the continuous support. They have really supported the registry. Nairobi County, they have been very, very supportive. They are also the consumers of this data. We share with them the data so that they can be able to disseminate this data for us. So all of you, we really, really thank you for the support. Thank you so, so much. Let me hand over back to Evans. Asante sana.
Thank you very much, Anne, and greatly appreciate for sharing these great points and speaking on this topic that is really you are really passionate about, and it clearly demonstrated in the presentation the passion for the cancer registration. So we have one last topic which will take us like 10 minutes. Then we will take the questions. Please put your questions on the chat and we'll be able to respond to all the questions at the end of this brief session. And the person to take us through that session is Sheila Wangui. Sheila Wangui is an advocate of the High Court of Kenya and certified mediator, legal auditor and certified secretary, bioethicist, data protection practitioner, and she currently serves as the data protection officer at KEMRI, mandated with assisting in monitoring internal compliance and as advising the Institute on data protection obligations, as well as conducting data protection impact assessment. And she is also the link person between the Institute and the office of the ODPC. I interest majorly in the field of medical and research ethics, medical law, and intellectual property. And it's an honor to hear from Sheila at this point on the legal aspect governing the surveillance data. Over to you, Sheila.
Good afternoon. How are you? So very briefly, we'll go through data protection because we cannot speak of data without mentioning issues, data protection and how to handle data protection generally. So for data protection, we are governed by the the Constitution 1 as the overarching legal framework. Under Article 31 of the Constitution, we talk about the right to privacy, and this is further bolstered by Article 35 that talks about correction and deletion of untrue and misleading information. So when we have this, it brings about issues data protection, and that is why and how we came up with the Data Protection Act, which came into force in 2019. And then under the Data Protection Act, we have established the Data Protection Commissioner. That is a regulatory authority or regulatory office that governs issues processing personal data, providing the rights for data subjects and obligations ascribed to controllers and processors of data. So the office, that is the ODPC, it is mandated to regulate processing of personal data, ensuring that the principles set out in Section 25 of the Act are followed, protects the privacy of individuals, establishes mechanisms to protect personal data. This is where we talk about data sharing agreements, data transfer agreements, and all other mechanisms, anonymization, pseudonymization, such alike come under that. Then it also provides data subjects with rights and remedies to protect their data from processing that is not in accordance with the Act. As we go through this, we'll see certain rights that are ascribed to the data subjects, which all data controllers and data processors must adhere to. So to give further strength to the Act, we have certain regulations that accompany it. We have the Data Protection General Regulations, complaints handling and enforcement regulations. These talk about what happens in instances of complaints, how complaints are handled, how certain enforcements are done, that is maybe fines, complaint procedures, such alike. Then we have controller and processor regulations. This talk to registration of controllers and data processors, what they can, what they cannot do, and the limits to which they can do certain activities to data that they're collecting. Then we have the civil registration entities regulation. This goes into the likes of the marriage registries, death registries, their conduct, how they can handle persons' data, the limits to which they can handle person data, and where and when they can store persons' data. So briefly into definitions, we have personal, defining what is personal data, what is sensitive personal data. So personal data is what is attached to you, what describes you on a very topical level. So we have your name, examples could be your name, your address, your mobile device, a photograph that shows an image of you. Then we go into sensitive personal data. This goes further into nitty-gritties of who this person is. And why it is ascribed as sensitive personal data is because it has the ability to identify you distinct from another person. So your race, your ethnicity, your sexuality, sex life, and all that. Then we also have another category of data, that is the genetic and biometric data. Again, gene sequencing, fingerprints, facial recognitions, all this can be used to identify particular persons. And when we're talking about genetic and biometric data, this also fall under the ambit of sensitive personal data, and it's regulated similar to any other personal data under the Data Protection Act. Just further explanation onto sensitive personal data, it could go into the details of your health status, your social origin, your beliefs, that could also be your religious beliefs. Again, genetic data, biometric data, details of properties that you own, your marital status, details of your family, that is your spouse, your children, all that fall under personal sensitive data. Then I've mentioned data controllers and data processors. So a data controller is a person, natural or legal person. A natural person is you and me, the person that we can see born. Whereas a legal person is an entity that has come to being through either an act of parliament or memorandum of association. There's an instrument which establishes this legal entity. So this, the controller is either this natural person or legal person who determines the purpose and the means for which data is being processed. So say, for example, KEMRI has collected data from participants in a study X. KEMRI becomes the data controller in that situation. It directs to another entity or even to itself how such data can be controlled, can be processed, and processing activities include sharing, anonymization, pseudonymization, and basically whatever process that you're going to conduct on that data. Then again, we have the data processor. This is the person who does these activities on that data, the storage, the transferring, the anonymization, all that. And for a data processor to be able to do these processing activities, they have to have gotten into a contractual relationship with the data controller, either dependent, either on their own or in collaboration with the data controller. They could both be processors. And the data controller, again, strictly is the one who guides or determines the processing activities to be done on such data. Then we have the general principles of data protection. These are what guide how we handle data, what you're going to do with this data. So we talk about lawfulness, fairness, and transparency. All data that we collect has to have a legal basis for which we are collecting it. It has to be stored and used in a transparent manner. Purpose limitation is whereby we collect data only in line with the purpose for which or a particular activity. So say we are collecting data in relation to cancer research, the data being collected can only be used for this purpose. That is what we talk about purpose limitation. When we talk about data minimization, we are talking about only collecting relevant data. So as Anne had said, at times your ethnic background is relevant to cancer registration and all that. So whereby the same is not relevant to that particular data set being collected, then it is not necessary to collect that subset or whatever other subset of data that is quote unquote being collected. Accuracy and accountability. Here we talk about the data has to be accurate. If it is personal data, your name has to reflect accurately to the person to whom that name is being ascribed to or being connected to. Accountability, you're able to tell or act on this data accountable to this person. So if a data subject comes back, I'm sorry, there's a bit of background noise. If a data subject comes and asks on how their data is being used, you as a data controller or the data processor can be able to highlight to them that their data has been collected, it is stored in particular place X, it is being used for particular process Y. Storage limitation, this talks about retention. How long can we retain data? For administrative data, different timelines apply. However, for research data, we find instances where some data sets are kept for an infinite amount of time. This is taking into consideration future research. So as we're doing the data storage, we take into consideration how the data is being used, whether it has been anonymized, and would there be instances of data breaches, so that we determine how long and where that data is going to be stored. Integrity and confidentiality, this talks to the data subject's privacy. It has to be maintained through, and in instances of data breaches, the data subject has to be notified that their data has been leaked, and due process has to be followed to ensure that the same cannot happen again. And then here we have the lawful basis for why data is being collected. One, the data subject has to give consent for why this data is being collected. Once we have consent, then it is okay to collect the data. It is okay to share this data. Performance of contracts, contractual obligations. If the data is necessary to ensure that a contract is performed end to end, then that also forms a legal basis. A legal obligation, this an instance would be like KEMRI, where amongst our mandates would be to advise the mother ministry, that is the Ministry of Health, on cancer issues, and that is why we have the cancer registry within the institute. So the purpose for which we collect cancer data is to fulfill this legal obligation. We have vital interest of the data subject. This mostly applies to hospitals whereby you cannot treat a patient without having their data, that is their health data, their background data, all that. It is necessary for their treatment. Then when we talk about public interest, the best example would be an incident of corona. People's data was being collected for purposes of surveillance, treatment, location, and all that, whereby the public interest outweighs your personal interest. So in instances where you cannot even give consent for this data to be collected, then the public interest supersedes your own personal interests. Then we have public authority. Here we have the registries. We have the birth and death registries. They are public authorities mandated to collect data, personal data. So that also flies therein. We have historical and scientific research. What Cambridge does with scientific research falls under the same ambit. And then we have the rights to the data subject, what I had mentioned earlier. They have the right to be informed, right to access their personal data, right to correction, amongst others. So the right to be informed, this comes in under informed consents, where at the point of collection, you have to inform this person what data sets you're collecting, why you're collecting them, in instances, if you're going to share this data, who you're going to share it with, how long you're going to store it, if you're transferring it out of the country, to which countries you're transferring it. Right to access personal data. This data subject has a right to come and access their data. They could do it through a formal request to whatever organization that has collected and stored their data. And this is free of charge. And the institute or the organization that gets this request has to comply within a 7-day period. Then right to correction. This is linked to accuracy, whereby a data subject can come in or request an organization or an institute to correct information that is inaccurate, untrue, outdated, or misleading. Again, the same is free of charge, and the organization has to comply within 14 days. Other rights include the right to deletion. This is where a data controller or a data processor is no longer authorized to access or manipulate that data. So a data subject can request for their data to be deleted. And even where this data has been shared with third parties, this is other organizations or other institutes, then they also have to delete this data. Whereby there's a request for data deletion and we refuse to share this data, we refuse to obey this request, then such decline has to be met with a justification. And then we have the right to data portability. This is linked to access of data. The data subject should be allowed to copy their data, to transfer it. It should be in a format that is easily readable. And the compliance period is usually 30 days. Then right to not be subjected to automated decision-making. Automated decision-making is whereby we use machine to make decisions. That is the AIs that we currently have. So for any processing activities, we should not subject data subjects to purely automated decision-making. The best example would be HR and job applications, whereby we find ATS CVs or ATS mechanisms to sift out appropriate persons to be interviewed. That should not be the case. Where we have automated decision-making, then we should also have a person, a human element to help with the decision-making. Then the data subjects, another right, the data subjects have the right to object to processing. So you could have an instance where a data subject consented to their data being collected, but thereafter they do not either feel comfortable to their data being processed or being shared or being used in a particular way. So they could deny for that data to be processed, either wholly or partly, or generally or towards a particular purpose. Within 14 days of accepting or receiving this request, a data controller, data processor has to comply with this request. Where they refuse, they also again have to give a reason as to why they refuse. Then we have instances where there are particular sets of persons who cannot consent on their own to give for their data to be collected or their data to be processed. Here we have minors. These are children. Again, as advised by the Constitution, anyone below the age of 18 is a minor. So where we need data from these persons, then we either access it through their parents or through their guardians. Those ones who are mentally incapacitated or have other disabilities that reduce their capacities to either consent to their data being collected or their data being processed, then they should have authorized persons to act as their guardians or administrators. This is where we also have powers of attorneys. Again, similar in other cases whereby, say, someone is out of the country and they cannot be easily accessed, then they could have someone authorized to handle or consent on their own, on their behalf. Also powers of attorneys in these cases. Then we have, when we talk about the data controllers and the data processors, with the rights ascribed to data subjects, the data controllers and the data processors have certain obligations. First and foremost, the primary obligation would be to register with the Office of the Data Protection Commissioner, which is the regulatory authority. Such registrations last for a period of 2 years, and you're obligated to renew it before 30 days before the lapse of the 2-year period. Then we are supposed to implement protection by design and by default. This is whereby we have mechanisms embedded within our systems to ensure protection of data subjects' data. Then there's an obligation to carry out data impact assessments. These are audits to ensure the soundness of our activities and our safeguards, how we are going to protect persons' data. Do we have adequate safeguards, say anonymization, say pseudonymization, the length of time with which we keep this data, are they adequate to ensure protection and confidentiality of these data subjects? When it comes to things like data sharing, before any data is shared, the data controller has to determine the purpose and the means of sharing. This is to ensure security of this data and why are we sharing this data. That lies under the purpose for which we are sharing. And before any data is shared, we have to get into data sharing agreements and data transfer agreements, which are enforceable under law. We have to ensure that both parties can legitimately get into these agreements and understand the enforceability of them. And in case of any breaches, then there's a liability ascribed to these parties. Again, similar to the data, what I've talked about, data processor contracts, when you are contracting or bringing someone else on board to do the data processing activities on your behalf, they cannot act without getting into a data processor agreement. These contracts outline the processing details, instructions, explicit instructions to the data controllers, the commitment on confidentiality, what security measures have been put in place to ensure data confidentiality, and what happens to the data upon conclusion of the agreement. So herein you could talk about either return of the data or destruction. If it is destruction, how this data is going to be destroyed, if there are any copies to be made, where these copies are going to be stored, how they're going to be transmitted, all that. Then we have, unfortunately, even with having all these safeguards, there are instances where data is breached. Here we have obligations in instances of data breaches. One, we have to notify the data subject in writing within a practically reasonable time. And the only exemption to this is where the data subject cannot be particularly identified. And then further to communicating to the data subject, we also have to notify the data commissioner, that is the ODPC, within 72 hours of becoming aware of the personal data breach. On this notice to the ODPC, at that particular time, say, for example, you do not have every particular detail of how the data breach occurred, you could only furnish them with details that you have at that particular time. And then as you continue with your investigations and find out other information in relation to the data breach, continue furnishing them with that information. Then again, another obligation to data controllers and data processors, we are obligated to have retention schedules. This speak to how long we're going to have the data. Upon the expiry of these retention schedules, what happens? Do we erase this data? Do we anonymize it and keep it infinitely? And then it should outline the purpose of the retention period, audits that are being taken, which audits required to be taken, and any action to be taken after the audit. In line, and which goes hand in hand with retention schedules, we have the data protection policies. All institutes that handle data, regardless of whatever kind of data you're handling, are required to have data protection policies. These speak to the nature of data being collected, exercise the rights of the data subjects have to be outlined within the protection policy, any complaints handling mechanisms, the purpose for which the data is being collected. The data retention schedule can come in here as an addendum or an annexure. If we have instances where you are collaborating with other organizations within your protection schedule, your protection policy, you could talk about the obligation to transfer, whom you're transferring to, and why it's being transferred. Then for the processors, they have to seek authority to engage any third party. Say KEMRI has engaged organization X, and the organization X wishes to engage another party Y, then they have to seek authority from KEMRI to engage this other party. So whereby persons fail to comply with provisions within the Act, then there are certain enforcements that are taken. One, there's the issuance of an enforcement notice. This is whereby you fail to comply with the provisions of the Act, and they specify the consequences of non-compliance with the notice, just basically telling you you have not complied and you need to comply. After the issuance of an enforcement notice and there's continued failure to comply, then the ODPC issues a penalty notice, which imposes a fine of not more than 10,000 for each penalty identified until the breach is rectified. And then there are certain exemptions. If you're processing household data, you're exempted from the provisions of the Act. National security or public interest, you're exempted from provisions of the Act. If there's an order of the court, you're exempted from the provisions of the Act. Then we have briefly go through cross-border data transfers. This is whereby you're transferring data from jurisdiction X to jurisdiction Y, for example, from Kenya to Uganda or vice versa. Before that is done, we have to ensure there are appropriate safeguards. There probably a decision made or concurrence with the Data Protection Commissioner. The transfer has to be a matter of necessity, and you have consent from the data subject. When it comes to issues of appropriate safeguards, you have to have comparable laws between the jurisdiction to which you're sharing the data. So for example, Kenya and Uganda do not exactly have comparable laws, so appropriate safeguards may not apply in this particular instance, but we could talk about getting into legally enforceable instruments. We could also talk about benchmarking, ensuring that there are appropriate safeguards. Then when we're talking about necessity, again, contractual basis and all that, consent for the data from the data subject is compulsory. Before any data is transferred, they have to consent to the data being transferred. I've talked about appropriate safeguards. There's ratification to the malleable protection, reciprocal data protection agreements, and contractual binding corporate rules. Then to finalize how KEMRI protects your data, we have anonymization and pseudonymization mechanisms. Then we have informed consent forms with our data subjects. Then before anything, we get into data sharing, data transfer agreements with whoever we are sharing or transferring the data to. We have training of staff, continuous training of staff to ensure that they understand the landscape of data protection and ensure that they know what they need to do. Continuous compliance audits, and also, again, compliance with the Data Protection Act. As Anne has said, we are registered with the Data Protection, Office of the Data Protection Commissioner, and they're assured of our compliance. So key takeaways: ensure all your services are compliant with the data protection framework, registration with the Office of the Data Protection. You develop the data protection and retention schedule policies, get into contractual agreements, that is the data sharing, data processing agreements. Then it's important to conduct data protection impact assessments, appointment of a data protection officer, which is optional. However, it is advisable to have one. Then ensure you have dedicated resources to ensure compliance, as well as promoting awareness and a culture of data protection. In brief, that is what I had, and thank you for listening.
Wow, thank you. Thank you so much, Sheila, for finishing right on time. We have just finished exactly on time. We wish to take only one question. We have responded to a number of the questions on the chat, but there is one question from, let me read, and Anne will respond. But feel free also, if you still have one more question, maybe you can still type on the chat. And possibly maybe you can speak to the issue of sustainability. How do you foresee the aspect of sustaining the Nairobi Population Cancer Registry beyond the current situation and beyond the current mandate?
Okay, thank you, Evans, for that question. So for the Nairobi Cancer Registry, as I mentioned, it began as a project actually that was being fully supported by donor funding. But in the year 2012, the Institute, noting that this was an important undertaking that needs to be there long term, they institutionalized it. So it was actually, now it moved from being a project, and it was now developed as a department within the Institute. So Nairobi Registry is within the Center for Clinical Research. It's a department there. And so then it gets, support from the institution. So issues to do with HR, so staff have already been employed who are full-time staff of the registry and are on payroll within the institute. The institute also recently, the Board of Management of KEMRI, they put a budget line for the registry so that there is a continuous budget line to support operations that are, demands funding, things to do with office supplies, things to do with transport for staff and certain things that requires funding. The Institute put in a budget line that, and they promise that it will, that budget line will be increased annually depending on the needs of the registry. So those are some of the mechanisms the Institute put in place to ensure sustainability. So it's not fully donor funded anymore. It is actually a department within the Institute with full-time staff working there. And of course, it's, as just like in any other department, human resource is still critical. So we are still, engaging the management to hire more staff for the registry. But basically the fact that it's now a department within the Institute, so it's more sustainable as opposed to when it was just a project. So in terms of sustainability, that's what the Institute has done. In terms of mandate, of course, they've been given an additional mandate as a center of expertise for the region, which means more responsibility, more work, but we are handling it well so far. We've really working with now stakeholders like the Africa Registries Network, like IAC, like National Cancer Institute in the US, even locally, National Cancer Institute, MOH. So working with partners, we are able then to also be able to handle our other mandate, our other global mandate of supporting the region. Yeah, thank you.
Thank you very much, Anne, and greatly appreciate for the responses, and thank you also for your attention. And we look forward to many other engagements. So feel free to reach out to us. We have all our contact information on the KEMRI website, and also the links to take you to the GICR e-learning series and many other activities that we will be conducting as Nairobi Cancer Registry. Thank you very much. Over to you, Nelson. right, Nelson, if you can hear me. Okay, seems Nelson, you are muted. I know we have gone past our time, but thank you very much for your patience, and thank you for the engagement on the chat. And thank you very much. We greatly appreciate for the support and what you have been doing, and what you are doing towards even supporting the cancer registries. Thank you very much. Feel free to log out.